Hi, everybody. We're just letting folks in. Give it just a couple minutes for folks to trickle in, and then we'll get started. Thank you for joining us today. Just give it one more minute. And folks are still coming in. Okay, I know that we have some very complex material to get through in just 1 hour, so I want to go ahead and get started. And I'd like to start by giving Florida Health Justice Project, for whom I'm the legal director, Katie DeBreer, just express our gratitude to Justice and Aging and our two panelists today, Amber Christ and Hannah Diamond, who have significant expertise in Medicare, including the interaction between Medicaid and Medicare. As you might know, they're doing a three-part series for us. Justice and Aging is participating in a three-part series for us. Today starts essentially their Medicare 101. And then we will continue on to cover D-SNPs, and that's going to be next Wednesday. And then the following Wednesday, rights in nursing homes, and that will be presented by Eric Carlson. Then in addition, I just want to plug that Florida Health Justice Project will be doing a Hot Topics in Medicaid eligibility, which will cover some recent changes to Florida Medicaid policy, as well as a bit of a review of the public health emergency unwind. That will be on October 22nd. And while this initial presentation on Medicare basics will not get CLE credit, we are working feverishly towards getting CLE credit for the next two-part series by Justice and Aging on the D-SNPs and the nursing home rights, as well as the Hot Topics and Medicaid eligibility. And then just one more plug, and I'll turn it over to our amazing experts. Florida Health Justice Project is doing an Ask a Lawyer event on October 23rd to allow folks to come in and meet with lawyers to ask individual questions about Medicaid. If you want more information on that, please reach out to me or Nicole LaRock, whose email you have from the registration of this series. So with no further ado, I would like to introduce Amber Christ and Hannah Diamond. Thank you guys so much.
Thanks, Katie, and thanks, Nicole, and thanks to the Florida Health Justice Project for having us here today. My name is Amber Christ. I use she, her pronouns, and I'm the Managing Director of Health Advocacy at Justice and Aging, and I'm here today with my colleague, Hannah Diamond. And we're honored to just be presenting to you on Medicare basics and next week on the D-SNPs. And I know Eric is really excited to be talking about nursing facility rights. So for those of you who might not know who Justice and Aging is, we are a national organization focused on eradicating senior poverty by increasing access to health and economic security for low-income older adults. And we really focus on older adults who have been marginalized and excluded from justice, including older adults of color, older women, LGBTQ plus older adults, older immigrants, and those with limited English proficiency. We're also a support center, so we provide a lot of education and technical assistance. That's why we're here today, and we answer a lot of questions. And we do that both at the national level, providing national webinars, and then do kind of in-depth trainings in states and for state advocates. At Justice and Aging, we're committed to centering equity in all of our work and addressing the enduring harms of racism and other forms of discrimination in all of our advocacy. So you will see that in terms of the policy priorities we focus on, as well as the way that we hire our staff and our board. And then there was a slide just right before this that you can go back to, that you can sign up for our network and get lots of alerts and information from us. We're constantly pushing out tons of information. So you will get a lot of emails from us, but you can just disregard the ones that don't mean anything to you. And I just want to say again, thank you for having us here today. We really want to make sure that folks in states understand the basics of Medicare and really to understand that's really building a foundation to understand some of the things that are impacting people who are dually eligible for Medicare and Medicaid, which is our real focus. So this is sort of a base building education for what we will cover next week, which is our dual special needs plans, which are a special type of Medicare Advantage plan. But for today, we're going to provide an overview of Medicare, including Medicare eligibility, enrollment, the cost of Medicare, how people can receive help with costs of Medicare, what Medicare covers, and then we'll do sort of a quick primer on care denials, including appeals, both in traditional Medicare and Medicare Advantage. And we'll just flag for you what we will be covering in next week's training at the end of this presentation. So those are our objectives for today. And with that, I'm going to turn it over to Hannah to kick us off.
Thanks so much, Amber. So first, what is Medicare? Medicare is a federal health insurance program that's the primary source of coverage for individuals ages 65 and older, and certain individuals who are receiving disability benefits, as well as those with specific qualifying disabilities. Medicare is run by CMS, the Centers for Medicare and Medicaid Services. But as you're also going to hear throughout the presentation, the Social Security Administration plays a role in Medicare, particularly in terms of enrollments. There are two categories of populations that can enroll in Medicare. As I previously noted, individuals who are ages 65 and older, and then individuals with disabilities, either those with qualifying disability benefits or those with qualifying disabilities, specifically end-stage renal disease and ALS. Medicare is an extremely important health insurance program in the United States. About 65 million individuals are enrolled in Medicare, and it's a really critical and key part of our healthcare system. That said, Medicare is not a comprehensive form of health insurance. There are specific benefits, particularly long-term services and supports, vision, dental, and hearing that are not included in Medicare. And so you're going to hear throughout the presentation how Medicare works with other forms of health insurance. I also want to note that Medicare is not a means-tested program. So eligibility is based upon age, disability, and then whether or not someone's paying a premium is based upon their work history. So there are four parts to Medicare: Parts A, Parts B, Parts C, and Parts D. So Parts A and B are often referred to as traditional Medicare, original Medicare, fee-for-service Medicare. Specifically, Part A is commonly called hospital insurance. This is where Medicare is paying for hospital or nursing facility stays, certain home health care expenses, and certain hospice expenses for terminally ill individuals. Part B is commonly referred to as medical insurance. This is where Medicare is paying for physician expenses, therapies, tests, x-rays, and medical equipment. Part C, this is what's called Medicare Advantage. This is in contrast to original Medicare or fee-for-service Medicare. This is where a private health insurance program is paid a capitated rate to provide coverage for Parts A and B, and oftentimes Part D. And these plans can often offer supplemental benefits beyond what is available through Parts A and B. And we're going to talk about in our next presentation next week a particular subset of Medicare Advantage plans known as dual eligible special needs plans that cater to people dually eligible for Medicare and Medicaid. And then we have Part D coverage, and this is prescription drug coverage. This can be offered either through a standalone prescription drug plan or through a Medicare Advantage plan. So as I noted earlier, Medicare is not a comprehensive form of insurance, and therefore individuals often have additional insurance to cover things that are not provided through Medicare or to help with the cost-sharing expenses associated with Medicare. So for low-income individuals, this is where Medicare savings programs come into play. Medicare savings programs are a type of Medicaid program. These are actually administered by the state, and these help individuals with costs associated with Medicare. And we're going to go through the various types of Medicare savings programs that are available. The low-income subsidy program helps low-income individuals with costs associated with Part D, prescription drug costs. I want to note, and this is something that we're going to talk about again throughout the presentation, but an individual can be either partially eligible for Medicaid or a full benefit dually eligible individual. So if an individual has partial Medicaid benefits, that means that they are only enrolled in a Medicare savings program. Whereas if an individual has full Medicaid benefits, they can access full Medicaid benefits like long-term services and supports and additional assistance with Medicare costs. Medicare also works with employer-sponsored insurance and retiree coverage. Individuals often can enroll in a Medigap plan. So just to note that Medicare works with other forms of insurance. So now we're going to go into eligibility. So eligibility for Medicare is based upon, again, age or disability, but whether or not someone is paying a premium associated with Medicare, that's based upon someone's work history. So most people qualify for premium-free Part A. For individuals ages 65 and older, they can qualify for premium-free Part A based upon their work history or based upon a spouse's work history. I want to note that unfortunately, this protection does not extend to domestic partners. So when I'm referring to work history, this is the level of work that typically entitles an individual to Social Security retirement benefits, so usually 40 quarters or 10 years worth of work. Individuals who are younger, so under the age of 65, can also qualify for premium-free Part A if they have a qualifying disability or qualifying disability benefit. So specifically, individuals who receive SSDI benefits or railroad retirement benefits and have been receiving those benefits for 24 months, they can receive premium-free Part A. Also, individuals with qualifying disabilities. So specifically, individuals with ALS or end-stage renal disease, these individuals can receive premium-free Part A without having to wait the 24-month period. It's important to note that if an individual is disabled and working and under the age of 65, there could be a premium that they have to pay associated with Part A, and we're going to talk about that in a few slides. So if an individual does not have sufficient work history or qualifying disability benefits for premium-free Part A, they can still qualify in particular circumstances and pay a monthly premium. This is common, for example, when we see immigrants who have moved to the US later in life, or individuals who don't have enough of a work history but are receiving disability benefits in the form of SSI. So in order to receive, in order to qualify here, an individual must be at least 65 years old and must be a US citizen or a lawful permanent resident with 5 years of continuous residency. And then in order to purchase Part A, they also have to be enrolled in Part B by paying an additional premium. And we're going to talk about what that is in a few slides as well. Okay. So eligibility for Part B. Part B coverage is available really to anyone who is eligible for premium-free Part A. But if an individual does not qualify for premium-free Part A, they can qualify for Part B if they're at least 65 years old and a US citizen or a lawful permanent resident with 5 years of continuous residency. Part C, so our Medicare Advantage plans. Just as a reminder, these are the private health insurance plans that are administering Part A and B benefits and often Part D benefits. Because within the Medicare Advantage space, generally these plans have contracted provider networks and individuals are often subject to prior authorizations before they receive a service. And as I mentioned before, we're going to talk about dual eligible special needs plans next time. But to be eligible for a Part C plan, an individual must have both Parts A and Parts B. And then Part D, again, these are prescription drug plans. These can be provided via Medicare Advantage plans or via a standalone prescription drug plan, and an individual must be eligible for Parts A and Parts B to enroll in Parts D. So here are options at a very high level, and we're just trying to show you the contrast between the two. So an original Medicare is fee-for-service Medicare. So an individual can receive kind of all parts of Medicare separate from one another. Parts A, Parts B, and Parts D, they all remain separate. And these forms of traditional Medicare also work with other forms of insurance. Then you have Medicare Advantage, which is, again, a private plan that is administering Parts A and B and generally also Part D. They're receiving a capitated payment for providing these services. These Medicare Advantage plans often offer supplemental benefits, and they also work with other forms of insurance. So just at a high level, you can have fee-for-service or managed care within Medicare. And then an individual can be dually eligible. So they can have both Medicare and Medicaid benefits at the same time. And as I mentioned earlier, an individual can be partially eligible for Medicaid. That means that they just qualify for a Medicare savings program to help with the costs associated with Medicare, or they can have full Medicaid benefits, which means that they can access things like long-term services and supports or transportation that's available through Medicaid, in addition to support with Medicare costs. Okay, so that was a lot of information to throw at you all, but now we're going to talk about enrollment. So it's really important to pay attention to Medicare enrollment rules, because if an individual gets it wrong, they can be faced with penalties that actually will remain with them for their duration of their time that they're enrolled in Medicare. So first, certain populations are automatically enrolled in Medicare Parts A and B. Individuals turning 65 who are currently receiving Social Security benefits or railroad retirement benefits, they're going to be automatically enrolled. Individuals who have been receiving SSDI benefits for 24 months will automatically be enrolled. Individuals with ALS will automatically be enrolled, but it's important to note that actually individuals with end-stage renal disease, they're not going to be automatically enrolled. So they're going to have to affirmatively enroll. And then individuals living in Puerto Rico, interestingly, will be automatically enrolled in Part A, but they will not be automatically enrolled in Part B. These individuals are going to receive a Welcome to Medicare packet, and that's going to be sent out 3 months before they become eligible, and then a reminder 1 month before their Medicare coverage begins. So for individuals who are not automatically enrolled, these individuals have to enroll during an enrollment period. Technically, I'll note that individuals who are eligible for premium-free Part A can enroll at any time, but most individuals actually enroll when they become eligible because they don't want to face Part B premiums. So for those who must pay a premium for Part A, individuals can enroll during, and also Part B, they can enroll during these 3 periods: the initial enrollment period, the general enrollment period, and then there are also some things that are called SEPs, or special enrollment periods, that I'm going to cover now. So the initial enrollment period, this is the 7 months surrounding an individual's 65th birthday. So it's the 3 months before an individual's birthday month, their birthday month, and then the 3 months after. If an individual signs up before their birthday month, their coverage is going to begin when they turn 65. If the individual signs up during their birthday month or the 3 months after, it's going to start the month after they sign up. If the individual does not enroll during their initial enrollment period, then they have to wait for what's called the general enrollment period, which occurs every year between January 1st and March 31st. If an individual enrolls during the general enrollment period, coverage will begin the month after the individual signs up, but I want to note that it's likely that they're going to have a penalty associated with signing up late, unless the individual qualifies for a special enrollment period. And so we have some special enrollment periods listed here on the slide. Probably the most common that we see is when an individual or their spouse still has insurance through their work. There's a special SEP for individuals who have employer-sponsored insurance. So when they lose that coverage, they qualify for an SEP that will allow them to sign up for Medicare without a penalty. There are additional SEPs that we've listed here that are associated with loss of Medicaid, things like a natural disaster or other exceptional circumstances that prevent someone from enrolling timely, and for individuals leaving incarceration. So now let's talk about some of those costs. So if an individual doesn't qualify for premium-free Part A, the cost can be very high, which you can see here on the slide. Premiums are based upon an individual's work history. So if an individual has less than 40 quarters, specifically if they have between 30 and 39 quarters, they're going to pay $278. If they have fewer than 30 quarters, they're going to pay a premium of $505. Medicare savings program specifically can help with premiums, and we're going to talk about those a little bit later. Part B always has a premium. The premium in 2024 is $174.70. This premium is deducted from an individual's Social Security or retirement benefits. And if an individual doesn't receive retirement benefits, Medicare will bill the individual for Part B premiums every 3 months. And again, Medicare savings programs can help with the costs associated with Part B. Part C, for the most part, these plans do not have costs associated with them. There are exceptions. So if a plan is offering additional services, they can charge an additional premium. If an individual sees an out-of-network provider or receives a service that is not covered by the plan, there can be costs associated there. And then with Part D, there are monthly premiums that vary. But again, I'm going to plug the low-income subsidy, also known as extra help, that can help with prescription drug costs. Okay, so here are some of those late enrollment penalties that I've been alluding to earlier in the presentation. Specifically, if someone enrolls in Part A late, there is a penalty of 10% of the premium for each 12-month period without coverage. Now, the nice thing about the Part A penalty is that this has a duration, a finite amount of time. So it lasts twice the number of years without coverage. So this penalty will end. Unlike the Part B penalty, this Part B penalty will follow individuals for the remainder of their duration while they're enrolled in Medicare. And this penalty is 10% of the premium for each 12-month period in which they were not enrolled. Part D, there's a really complicated formula to determine the penalty amount here. But the big picture takeaway is that you have to be really careful in terms of when an individual can enroll and make sure that they're not missing their enrollment period. And note that special enrollment periods can help with making sure that someone doesn't get a penalty if it's not appropriate. And then also the Medicare savings programs can help, and LIS can help with the costs associated with Medicare. I just want to note that there are some other costs beyond premiums that we haven't talked about yet, and I'm not going to go into this slide in too much detail, but I just want to note that in addition to premiums, there are deductibles, there is coinsurance, there is out-of-pocket costs. So it's important to note and know these things that are associated with Medicare costs, and then make an even bigger plug for the Medicare savings programs. So I've talked about the Medicare savings programs a lot. What are they? There are 4 of them that we're going to talk about today. The biggest difference between them is the eligibility criteria, and then also what they're offering. So the QIMBY program, specifically the Qualified Medicare Beneficiary Program, this is for those with highest needs. So this is the lowest income program, and this is providing the greatest level of protection for individuals. Second tier kind of these Medicare savings programs, we have the SLIMB program, the Specified Low Income Medicare Beneficiary Program, and the QI program, the Qualified Individual Program. These provide protections that we'll show you on the next slide. And then our fourth category is the Qualified Disabled and Working Individual Program. These are the names at the federal level. States can often name these programs by their own unique names. And I'll just add to the confusion here, these are called Medicare Savings Programs, but these are actually Medicaid programs that are administered by the state Medicaid agency. So here's what each of these programs looks like. The Quimby program, which I mentioned, is providing the most robust protection for individuals. So this is Medicare Parts A and B premiums, deductibles, and also co-payments. And this also means that an individual enrolled in Quimby, does not have to pay for Medicare covered services. So the cost sharing protections for Quimbys are very robust, which makes this a very important program. The SLIMB program and the QI program, these are providing individuals with assistance with Medicare Part B premiums. And then our Qualified Disabled and Working Individual program, this is helping individuals with Medicare Part A premiums. And I want to note for the Qualified Disabled and Working Individual program, like it's understood in the name, this is for individuals who are disabled and working. The other thing associated with these Medicare savings programs is you might hear like a Quimby Plus or Quimby Only. This denotes whether or not someone has full scope Medicaid or not. So the plus means someone has full Medicaid benefits, and the only means that someone just qualifies as a partial benefit dual, so they only have that MSP program. And then finally, for these Medicare savings programs, I'm just going to plug the low income subsidy. Once an individual is enrolled in a Medicare savings program, they're deemed eligible for LIS, the low income subsidy, which is often referred to as extra help. This helps individuals pay for costs associated with Part D, so their prescription drugs. And we just have a note here that this year, the LIS coverage actually became more generous. And with that, I'm going to pass it back to Amber.
Thanks, Hannah. Before I dig into Medicare coverage, I wanted to lift up a question we got regarding individuals being in nursing facilities who often come in with a Medicare Advantage plan, and then the nursing facility tells them that they need to disenroll from that Medicare Advantage plan. This is a very common scenario we hear about. I will just note that people do not, what they should do if they're going into a nursing facility is understand what their Medicare Advantage plan is going to cover in the facility. Medicare Advantage plans, unlike traditional Medicare, have a network of providers. So you have to see in-network providers, including the nursing facility being in network and accepting the Medicare Advantage plan as payment. But also sometimes those contracted providers within nursing facilities may not accept that Medicare Advantage plan. So if someone's receiving skilled therapy, for example, within the nursing facility, or it could be the prescription drugs that maybe the facility is using a specific vendor for those drugs, and that's not a contracted provider. So if someone has a Medicare Advantage plan and they're discharging from the hospital, they should be checking with their Medicare Advantage plan and with whatever facility they're going into to make sure that everything is covered. That aside, the other issue we see a lot is that nursing facilities will still want you, even if they're accepting a Medicare Advantage plan, to disenroll from that Medicare Advantage plan because it's overly burdensome for the nursing facility. That is not a requirement for people. They have the choice of whether they want to do that. But sometimes the issue is that Medicare Advantage plans, particularly in nursing facilities, will deny prior authorizations. This is an area in which this happened to my grandmother. She's 90 years old, had a fall, went into a nursing facility with a Medicare Advantage plan, and the Medicare Advantage plan denied her nursing facility stay. And we had to do an expedited appeal, which we'll talk about in a little bit. So there are really valid reasons for wanting to disenroll from that Medicare Advantage plan, possibly if you're in a nursing facility. The big thing I want to drive home here is that there is a special enrollment period for people. Hannah mentioned the special enrollment periods. For people who go into a nursing facility and for people who leave a nursing facility, they have a special enrollment period to change their coverage. So they don't have to wait throughout the year, they can they can choose a Medicare Advantage plan again when they leave a facility, or they can go to traditional Medicare while they're in the facility, and they can use that special enrollment period to do that. I can put the link to the special enrollment periods in the chat, but just wanted to cover that question. And that is something that we frequently see when people end up having to go into a nursing facility and are already in a Medicare Advantage plan. All right, moving ahead to coverage, and I'm just going to go into a little bit more detail here about the different parts of coverage that Hannah already covered. So as Hannah noted, Medicare Part A is the hospital benefit. It's what we really think of the inpatient benefit. So it's going to cover the inpatient hospital stays. It's going to cover hospice in most instances. It's going to be covering that skilled nursing facility care for the first 100 days. First 20 days in full, the next 80 days, there's cost sharing. And a lot of times it can cover home health. Part B has a role in some of these as well, but predominantly that's Part A paying for those types of services. Part B is what we like to consider as our outpatient benefit. This includes doctor services, specialty care. You're going to, your normal doctor visits that you're going to. It also covers home health services in a lot of instances, durable medical equipment, our mental health services. And in some instances, it's also covering prescription drugs, particularly when they're being injectables, when they're being injected by a medical provider. Usually that's covered under Part B rather than the prescription drug benefit Part D. We talk about Part C, as Hannah noted, that's our Medicare Advantage private enrollment. Medicare Advantage plans will cover both, they are required to cover both Parts A and Part B services. So no matter what, the Medicare Advantage plan has to cover everything we see in traditional Medicare when it comes to Part A and Part B. Some Medicare Advantage plans, it's pretty limited, will not include the Part D benefit, but typically most Medicare Advantage plans are also wrapping in those prescription drug benefits. And then as Hannah noted, the Medicare Advantage plans can also offer supplemental services or benefits that aren't covered in traditional Medicare. So things like dental, vision, and hearing that are not covered under Medicare, traditional Medicare. And now they're providing a whole range of services beyond that. One thing we hear a lot about are the cash cards or benefit cards that allow people to buy groceries, for example, as well as a host of other types of services. So supplemental benefits have exponentially grown as they're being provided by Medicare Advantage plans. And then of course there's Part D. And like I said, Part D can be provided under a Medicare Advantage plan, but also through a standalone prescription drug plan. And that includes most people's prescription medications. Of course, if you're dually eligible, there are some instances where Medicare might not cover a drug that Medicaid might cover. So there is some additional Medicaid protections or Medicaid coverage of prescription drugs in certain instances. Moving to the next slide, Medicare and You is the handbook that every year CMS sends out to individuals, and it is a wealth of information. If you're ever just looking to see like they're trying to write it in plain language, everything you want to know about Medicare, this is where you want to look. And we've done a lot of work over the years to improve the versions of Medicare and You. For example, this upcoming year, they're going to include more information about Medicare savings programs, which is a really good addition. And Medicare and You is now available in multiple different languages, so it's been translated. So this is a really valuable resource for you as advocates and people helping individuals eligible for Medicare, but also clearly for people who are eligible for Medicare. All right, next slide, Hannah. Of course, our focus at Justice and Aging, working with low-income older adults, is how Medicare works with Medicaid, or oftentimes how Medicare doesn't work with Medicaid. But broadly speaking, Medicaid is always the payer of last resort. So if there's other primary coverage, it's going to be primary, and then Medicaid will be the payer of last resort. So in the instance of Medicare, Medicare is going to cover first, and then Medicaid will be the secondary payer. The only time when Medicaid becomes kind of primary is when an individual is exhausted, like their Medicare covered benefits, like through a Medicare Advantage plan, and then Medicaid's offering more. That happens a lot say, for example, you are enrolled in a Medicare Advantage plan that's offering dental, but Medicaid is also covering dental. You wouldn't use your Medicare dental benefits first, but usually the Medicaid benefits are more comprehensive. Not always the case, but in most states are more comprehensive than what the Medicare Advantage plan is offering. So you would exhaust those benefits and then use Medicaid. And then, of course, Medicaid can be used as primary when it's a benefit that's not covered by Medicare or a Medicare Advantage plan. And that most often happens when it comes to home and community-based services and long-term services and supports. So if you're in a nursing facility longer than 100 days, Medicaid's going to be your primary payer. And of course, Medicare, other than the home health benefit, doesn't cover the home and community-based services like personal care services or assisted living that Medicaid would be primary for. So clearly Medicaid becomes primary then. If we turn to care denials and appeals, we're going to, this fairly high level here. We don't want to get into too much detail, but what people can expect in traditional Medicare when they're getting information about what is covered or what is notably not covered, there are certain notices that they'll receive. So there's an advanced beneficiary notice of non-coverage that people will receive if something isn't a covered benefit. If it's with regard to home health, they're going to get the home health change care notice. There's also the notice of Medicare non-coverage. And then there's messages like a notice of hospital discharge rights. I also wanted this last one, the moon notice that it's affectionately called. This is a big problem that probably a lot of you have heard about, is that someone goes into hospital and they think that they're being admitted and are inpatient, and Medicare then Part A would be paying. But in fact, they're admitted on what's called observation status. And this has real implications because if you're admitted under observation status, you're not technically inpatient. So it's Medicare Part B that is paying. And you might think, oh, that doesn't matter too much, but it does. It matters in terms of like cost sharing, for example, but it also matters if you're going into a nursing facility afterwards, because if you're under observation status, you don't have the inpatient 3-day qualifying stay from Medicare to pay for your nursing facility coverage when you go into the nursing facility. And so that can have real ramifications on the out-of-pocket expenses that people will face when going into that setting. So the moon notice is supposed to be giving people the notice of their observation status and then allowing them to appeal that observation status designation. But also just giving them a heads up, like, you know, Medicare may not pay for your nursing facility stay if you're going into a nursing facility. So some really important notices here for people and for you all to know about. And then we can open this up, but we also have questions about to you all, if you had feedback on if you've seen issues with notices, and if there are follow-up questions you would like us to answer with regard to notices. Next slide, Hannah. When it comes to appeals under traditional Medicare, keeping in mind that just like fee-for-service Medicaid and Medicaid through managed care, the appeals processes look slightly different. So under traditional Medicare, individuals can appeal a coverage and payment decisions. Of course, it is incredibly important to pay attention to the dates on those notices and the appeal deadlines on those notices. Under traditional Medicare, there are fast track appeals for hospital discharges and things like terminations of skilled nursing facility and home health services. So people can take advantage of fast track appeals. Next slide. In terms of levels of appeal, there's always under traditional Medicare, there's the initial determination and the Medicare summary notice. And then after that, there's a first level, which is the redetermination. And then the second level, which is a reconsideration. Let's just make the words as close to together as possible. But at the redetermination level, the next decision is made by the Medicare Administrative Contractor, or MAC. And you have to appeal within the given timeframes. There always are, you know, good cause exceptions, but obviously much better to appeal within the given timeframes. And then at the second level, those appeal decisions are made by what are called the qualified independent contractors. And you have to file those appeals within 60 days of the redetermination. Next slide, Hannah. After that, we go to the third level. If you've received a denial then, which is the administrative law judge, which you have to have a claim and dispute of $180 or more in 2024. You lose at that level, you can go up to the MAC, the Medicare Appeals Council, and then the fifth level up to federal district court, if it's over a certain amount. A lot of this feels to me very, so I did a lot of Social Security disability appeals in my prior life as a legal services advocate. And this Medicare, the traditional Medicare route feels very similar at these levels as a Social Security disability appeal. Next slide, Hannah. Turning to Medicare Advantage, it's slightly different, and people are going to get different notices because they're not coming from traditional Medicare or from CMS, they're coming from the health plan. So there's the notice of Medicare non-coverage, but then there's the plan denial notice. Again, similarly, there's going to be notices, hospital discharge rights, and the moon notices still has to be given if someone's placed on hospital or on observation status in a hospital. Next slide, Hannah. I do want to point out some new guidance with regard to the grievances procedure and coverage determinations under Medicare Advantage. You have with regard to a Part B drug that should be covered by the plan. So you can ask for this additional information. Doesn't come up all that often, but nice to know that there's this additional guidance regarding Part B drugs. Next slide, Hannah. Then if we look at the appeals, so there are 4 options if someone is denied or dissatisfied with the decision from the health plan. There's obviously the normal appeals process. There's the expedited appeal. That's if medical conditions warrant an expedited appeal. And then the health plan has to make a decision within 72 hours. There's also a fast track appeal like we saw in traditional Medicare for when there's like a discharge from the hospital or from skilled nursing facility or home health. And then you also have the right to file a complaint through grievance procedures. So there's a complaint process. On the traditional Medicare side, there's also a complaint process. It's by calling 1-800-Medicare. This complaint process is through grievance procedures, and you're making a complaint about the health plan. So you're calling the health plan and filing a grievance. You can also escalate that to other levels of Medicare, but you start with the Medicare plan. Next slide. So the appeals process is triggered with written denial or failure to grant covered services within 14 days of service or within 30 days for payment. Next slide, Hannah. And then there are 5 kind of steps or levels, which look kind of similar to traditional Medicare, but there's reconsideration by the plan, 60 days to appeal. There is the independent review entity that then looks at the plan's response, and then you can go to the administrative law judge, the MAC, and then federal court. Similar, then it starts to look much more like traditional Medicare. The difference is really with that independent review entity looking at the plan denial. All right. So Medicare appeals and Medicaid. So this is just kind of flagging for folks that the Medicaid provider billing manuals can have instructions on the time frame where Medicaid kicks in after a Medicaid denial. So really this is thinking about when there's overlapping services. So durable medical equipment is one of those instances. There are other instances where you might need a Medicare denial in order for Medicaid to kick in, or you might not necessarily need a denial, but the provider is saying you do. The Medicaid provider billing manuals will usually provide guidance on how the Medicaid coverage will work if there's a Medicare denial. We most often see this with durable medical equipment, particularly like power wheelchairs. On the Medicare standard for using a powered wheelchair is that you have to, quote, be homebound. In Medicaid, there is no such requirement. And so Medicaid will actually be who authorizes the use of the wheelchair because the Medicare standard is far more restrictive. So there are just specific ways to navigate those appeals that are typically laid out in the provider billing manuals. And then next slide, Hannah. So just flagging for everyone for the next training, we'll be turning to dual eligible special needs plans. So these are specific types of Medicare Advantage plans that are targeted specifically for dually eligible individuals. I said specifically a lot there, but they're special types of Medicare Advantage plans that are supposed to make the coordination of care between Medicare and Medicaid look better or work better for people who are dually eligible. And in that training, we're going to be covering the basics of what those are. We're going to be looking at the landscape of D-SNPs in Florida, flagging that there's a lot of D-SNPs in Florida. And then we'll have some FAQs that we frequently asked questions that we get about D-SNPs that we'll cover during that training. And then lastly, we'll leave you all with some resources. Clearly, Medicare.gov has a ton of information on Medicare, the Medicare and You Handbook. Florida Shine, an incredible resource providing Medicare enrollment guidance, our counseling, and other help with Medicare issues. We also have, we run the National Center on Law and Elder Rights as Justice and Aging, and we have a Medicare legal basics training that you can refer to, including a paper that lays out the Medicare basics and a webinar that goes through all of this in even more detail if you're interested. So definitely point you to that resource. And then the next slide, Hannah. And then we have a ton of information about Medicare savings programs. You can look at the National Council on Aging website to look at eligibility and coverage. You can look at CMS's fact sheets. We also have a NICLR paper and webinar recording on Medicare savings programs that we just did last month that will be available on the NICLR website soon. And then we can open it up for questions, Katie and Nicole.
Yes, that was wonderful. Thank you guys both so much. I learned a lot being a Medicare novice myself. So does anyone have any questions for Hannah or Amber? I appreciated dropping them in the Q&A. And probably need to keep doing that, I think, just given the webinar format. It was so, oh, here we go. Actually, this is a question for us. Yes, we will absolutely make the slide deck available as well as a recording on our website. As long as we get proper permission from Justice and Aging, we can do that. It was a lot of information. I know I will be going back to it. All right. Well, again, Amber and Hannah, thank you so much for your time. We're really looking forward to next week's presentation on D-SNPs. And please note that we, again, are working on getting CLEs for those next 2 sessions. So please come and attend, have your lunch, and earn a little credit too. All right, everybody, have a great day.
Thanks all.